Good morning. My name is Dr. Sharath, and I am an anesthesiologist and an emergency medicine physician. Most of you wonder what anesthesia is all about, what anesthesia is given to the patient, how it acts on the patient, and how the patient wakes up from anesthesia. In this first of a series of modules, I will tell you what anesthesia is all about. For most of you, anesthesia is quite obscure. You may have undergone a surgery and you may have remembered the surgeon's name and the surgery, but not quite the name of the anesthetist or the kind of anesthesia that was administered to you. This talk is to familiarize you with anesthesia. Over the next half hour, I will take you through what anesthesia really is, the types of anesthesia in use, the drugs used in anesthesia, and the assessment of a patient who will undergo anesthesia. There are a lot of myths surrounding anesthesia and anesthesiologists. The word aesthesia is defined as the normal ability to express sensation, perception, or sensitivity. In other words, it is the ability to experience temperature, pain, touch, and pressure. Let's say I give you a cup of coffee. What you experience is warmth in your palms when I hold the cup of coffee. Let's say I hold your arm and you can feel my hand on your arm. This is touch. If I grip your arm a little harder, that is pressure. And if I pick you with a needle, you will feel pain. What anesthesia does is abolish all of these sensations. And this is exactly what a surgeon needs so that he can complete his surgery successfully. Anesthesia is fairly a new science with respect to the earliest medical discoveries. And it hasn't come easy because most of the techniques that came into use came by trial and error. The earliest anesthesiologists were surgeons and dentists, and they were so overcome by the pain that their patients were undergoing, they decided to improvise and do something about it. One of the most notable discoveries and names to remember is William Thomas Morton, a dentist who in 1846 administered ether to his patient, Abbott, who had a tumor removed from his jaw by a surgeon called Dr. John Collins. This was the first demonstration of an anesthetic gas on a patient, whereby the patient had no pain during the procedure. Here you can see ether was administered to a patient called Abbott for the tumor in his jaw. Here the surgeon was Dr. John Collins. What is ether? Ether is a pleasant smelling, colorless, and highly inflammable liquid. It has a boiling point of about 34.5 degrees Celsius, which means it needs to be kept under pressure or it needs to be kept in jars so that it doesn't evaporate easily. Here's an ether bottle vaporizer dating back to 1920. To commemorate the day that the first anesthesia was given to the patient, we celebrate it as a World Anesthesia Day, and it is celebrated on the 16th of October every year. So what is required of an anesthetic drug or an anesthetic gas? There are 5 A's that one should remember that a drug causes. The anesthetic drug should cause amnesia, that is the ability of a patient to not remember the process of the surgery. Anesthesia, the ability of the patient to lose sensation. Anxiolysis, the ability of the drug to relieve anxiety of the patient. Areflexia, to cause the patient not to react to stimulation. And analgesia, the ability of the drug to decrease the pain that the patient has during the surgery. However, amongst the drugs used in the present day, not one of the drugs causes all of the above actions. So what we administer is a combination of drugs that cause all of the above. Broadly, anesthesia that is given in the operation theater can be general anesthesia or regional anesthesia. For those of you who would like to have surgeries above the level of your abdomen, general anesthesia is the anesthesia of choice. And for those of you who have surgeries to be done over your abdomen and lower body, regional anesthesia is what is preferred. What you can see here is known as the Anesthetic Workstation. So you have the ventilator, you have the patient monitors, you have all of the equipment necessary to make sure that the patient breathes fine during the surgery, and you have all of the equipment necessary to be administered to the patient when the patient is having a critical episode. General anesthesia is a process by which we calm you, induce you to a deep sleep, make sure you don't move during the surgery, and make sure your body doesn't react to the stimulation during surgery. And we also make sure that you don't have pain. This is when we use a combination of drugs that we inject into your veins, as well as the gases that we administer. The gases that we administer are inhalational anesthetics, that is nitrous oxide, and compounds of ether. Once the above goals are established, you will not be able to breathe because you're in a deeper plane of consciousness. This is when it is upon us to control your breathing. Our aim is to make sure that the oxygen enters from your mouth to your lungs and carbon dioxide is being exhaled by you throughout the operation. We employ a set of procedures known as airway management, which means we insert a tube inside your trachea so that the oxygen and anesthetic gases reaches your lungs. So what you can see here is a process of intubation in which we insert a plastic tube right into your trachea via which the oxygen reaches your lungs. The surgeries can last anywhere between 1 hour to 20 hours and sometimes even longer. So we are present before, during, and after the surgery, and the anesthesia will last as long as the surgery lasts. And since you are in a deep sleep during the surgery, we wait until you wake up after the surgery is over. The waking up can take anywhere between 10 to 15 minutes. Contrary to the common perception, our eyes and ears are constantly looking for things that can go wrong during the surgery. Is your heart beating properly? Is your blood pressure all right? Is there too much blood loss during the surgery? Are you properly hydrated? Are your lungs functioning all right? All this and more while you're in the deepest of sleep. And we are equipped to handle emergencies. It is said that the surgeon may be the captain of the sailing ship, but the anesthesiologist is the captain of the sinking ship. We are the ones who make sure the ship is afloat during the surgery. Let me explain to you what regional anesthesia is. For short surgeries and surgeries below the level of the sternum, what is preferred is regional anesthesia. It could either be spinal anesthesia or epidural anesthesia. Let's say, for example, you have a fracture of the bone in your leg. The surgery will last about 2 hours to get the bone fixed. This is when we inject a local anesthetic in between the vertebrae of your back and directly into the cerebrospinal fluid. The local anesthetic then acts on the nerve roots of your spinal cord and abolishes pain from your abdomen downwards. The spinal anesthesia may act between 2 to 4 hours, after which sensation will slowly get back to your legs. This is the type of anesthesia where you can talk and be aware of what is happening around you. For those of you who have been pregnant and have wanted to deal with the over-excruciating labor pains, you would have to ask for epidural anesthesia. The epidural space is a space that surrounds the spinal cord. So in cases when the pain of surgery may be present even after the surgery is over, we insert an epidural catheter into the space. During and after the surgery, a constant and slow amount of local anesthetic is constantly being deposited in the space. The local anesthetic then diffuses through the epidural space and gets deposited in the spinal cord. And once it starts acting on the spinal nerve roots, the patient won't have pain. Epidural anesthesia is more challenging technique as compared to the spinal anesthesia, and the anesthesia takes a little more time to start acting. However, regional anesthesia is not limited to just your upper body or lower abdomen. Let's say you have landed with a fracture of the bones of your arm or forearm. Now the arm and the forearm is supplied by nerves arising from the spinal cord of your neck. They run through the sides of your neck, above your ribs, and branch out into smaller nerves that supply your shoulder, arm, forearm, and hands. This is when we apply what is known as a brachial plexus block. We use ultrasound that can identify the nerves by sending ultrasonic waves into the neck. Then we use a very fine needle and inject local anesthetic directly to where the nerves are located. This removes the pain and sensation from the shoulder all the way down to your fingers. The advantage of local anesthesia is that the effect of the anesthesia stays long after the surgery gets over. So you won't have pain even after the surgery, a technique called post-operative analgesia. Let me now come down to the drugs used in anesthesia. Now that we've seen the different types of anesthesia, I shall now move on to the kind of drugs used in anesthesia. A drug that is used primarily to make someone sleep, an action called hypnotic, is given by a class of drugs called benzodiazepines. They are the same class of drugs that one takes as sleeping pills, only this is injectable. Once we administer the drug, you will feel sleepy, but just not enough to go into a deeper plane of consciousness. Then we enter into the process of inducing you to a deep sleep. The conventionally used drug in most hospitals is propofol, an oily white-colored fluid. The effect of these drugs lasts anywhere between 15 to 20 minutes, and you will still breathe when the drug is inside your veins. We also administer a drug called fentanyl. Now, fentanyl is a compound of morphine, only much more potent. The process of introducing a tube inside your mouth and into your trachea is a stressful process. And so fentanyl takes away the pain during this process. Fentanyl is a painkiller that is used across all the hospitals around the world. What causes you to remain in sleep and not wake up during the surgery are anesthetic gases. Now, the earliest anesthetic gas to be used was ether, and then came chloroform, which an epidemiologist called John Snow used on Queen Victoria during the birth of her 7th child. Some of the anesthetic gases that were in use over the course of the last century were ether and chloroform. But what we use now are compounds of ether. Anesthetic gases such as isoflurane, sevoflurane, desflurane, and halothane are commonly used in hospitals across India and the world. So given here is an anesthetic gas called sevoflurane, which is widely used in hospitals across India. These gases make sure that you remain in sleep for the duration of the surgery. And once the surgery is done, we stop administering the gases just in time for you to wake up. Now, when you're undergoing surgery, we, the anesthesiologists, are in control of your breathing, heart rate, blood pressure, and pain. Every drug that we administer to you is in graded doses according to your body weight, neither too less nor too more. And in the event of administering more than what's necessary, there is nothing untoward that can happen. The anesthesiologist stays until the effect of the drug is worn off and the patient is saved. The commonly heard phenomenon called anesthetic overdose is a myth. Let me now explain to you the assessment of a patient undergoing anesthesia. It is commonly known as a pre-anesthetic assessment of a patient. The first person, a patient who's undergoing a surgery, sees after the surgeon is the anesthetist. This is an important event because we assess how fit you are to undergo the surgery. Are you physically healthy? Do you have hypertension, diabetes, or a heart problem? Do you have trouble breathing or do you have asthma? Are you passing out urine without any problem? Do you smoke or drink frequently? Do you take drugs? The areas that affect you prior to surgery may be exaggerated during the process of surgery. Your blood pressure would be that much more difficult to control. Your high sugars would cause swings in your heart rate and blood pressure. If you have asthma, your lungs may not function very well under the effect of anesthesia. Do you do physical exercise? Can you walk briskly for 2 kilometers without feeling breathless? We assess how fit you are based on the concept of metabolic equivalence. You are said to have more than 4 metabolic equivalents when you can climb up to the second floor without feeling breathless or tired. Someone with greater than 10 milliequivalents is someone who can jog, playing an intensive physical sport like swimming or playing football. All of these are important because they can influence what happens inside the operation theater. The fitter you are before the surgery, the easier you will recover from surgery. However, if you do have a long-standing disease that has affected you before the surgery, it has to be controlled. This can either be achieved by taking medicines or doing exercises. Stopping smoking and alcohol can go a long way in making sure nothing untoward happens during or after surgery. The American Society of Anesthesiologists grade patients depending on how fit they are. A perfectly healthy person would be graded as an ASA 1. Someone with an uncontrolled medical disease would be ASA 3. Someone who has a disease that is a constant threat to life, for example, a patient with a heart attack who needs surgery, is ASA 4. All of this would be explained to the patient and the patient's attenders. The risk to a patient who is in ASA 4 is much more as compared to someone with an ASA 1. The element of risk is a constant factor in the practice of medicine. If you are a patient or a patient's attender, the concept of risk would be explained to you. A low-risk surgery is the likelihood of a complication occurring to the effect of 1 in 1,000 or 1 in 10,000. How likely are you to face an accident while on your way to work or the hospital? That is low risk. Someone with a high risk is the likelihood of an adverse event occurring to the effect of 1 in 100 patients undergoing the same surgery. Someone placed in between the above faces a moderate risk of a complication during the surgery. Let me now explain to you what the role of an anesthesiologist is. Now that we have seen the types of anesthesia, the drugs used in anesthesia, and the assessment of a patient who will undergo surgery, the other question that some of us face is, what do we do? What is our job profile like? The anesthesiologist does all what I have mentioned so far, but his role goes beyond just what he or she does inside the operation theater. Checking on the patient before and after the surgery is vital and is covered by the anesthesiologist. Manning the intensive care units is something that the anesthesiologist does. Pain during any point after the admission and during and after the surgery is managed by the anesthesiologist. At any point in time, when a patient has a cardiac arrest, the anesthesiologist is called to resuscitate the patient. What you see here is an army setting where a number of people rush to the patient to resuscitate the patient. Resuscitation is a set of maneuvers brought into play to restart an arrested heart. Once a patient loses consciousness, he or she cannot breathe. An anesthetist is called upon during these times to establish an airway so that the patient gets oxygen and can breathe again. Like all professionals, we use instruments and machines to carry out our jobs. Our profession is intimately linked to the use of ventilators inside the intensive care units and the operation theaters. We are there when the child is born during a cesarean section and when a patient with multiple diseases takes his last breath in his ICU. We are there when a patient's heart stops anywhere inside the hospital and when the patient's heart slows down during a critical point inside the operation theater. We are there during every step of the operation and make sure you are fine until you open your eyes after the surgery. You may not remember us, but we are there keeping a watchful eye during every second of your time under the knife. So the next time you're undergoing a surgery, ask who your anesthesiologist is and we'd be glad to help you out.